Hi everyone, my name is Suhani. I am a recent graduate of the PGY2 Oncology Pharmacy Residency Program at Cleveland Clinic, and I'm excited to be sharing this presentation with you today covering the basics of bone marrow transplant in the pediatric population as part of the Pediatric Pharmacy Association Core Competencies series. I have nothing to disclose. The objectives of this presentation are to be able to define bone marrow transplant or BMT and types of transplant, summarize conditioning therapy and clinical pearls of medications used, to be able to analyze post-transplant complications for pediatric BMT recipients, and finally to be able to evaluate clinical scenarios for pediatric BMT through assessment questions. So before we dive into the presentation, I wanted to display a list of common abbreviations that I will use in my presentation. So bone marrow transplant is a curative treatment for childhood malignancies, hematologic disorders, immune deficiencies, congenital metabolism disorders, and bone marrow failure. The mechanism of action of bone marrow transplant varies based on the disease. So bone marrow transplant, abbreviated as BMT, may also be referred to as hematopoietic stem cell transplant, or HCT, and its name is indicative of the procedure and also the intent. Mature blood cells, both healthy and unhealthy, originate from less differentiated stem cells. And bone marrow transplant is used for many reasons that we will discuss in the next few slides, but some of them being that chemotherapy for certain malignancies primarily targets rapidly dividing cells, and stem cells might be spared, which allows the risk of cancer recurrence. For certain diseases, we would like to administer high doses of chemotherapy or radiation, and that can damage the bone marrow. And in other diseases, they may hinder function of the bone marrow or cause damage to it to prevent optimal function. So bone marrow transplant is utilized essentially to reconstitute the blood system. Prognosis following bone marrow transplant is impacted by the underlying disease, infections, and other complications, the latter of which we will discuss in this presentation. So there are two types of transplant that we will discuss. The first is autologous transplant. In autologous transplant, the patient serves as the donor. First, stem cells are mobilized to release from the marrow and into the bloodstream. Stem cells are then collected from the bloodstream and frozen until they are needed. Following collection, high-dose chemotherapy is administered to remove or partially remove the immune system. Then the cells that were frozen are thawed and administered back to the patient. Following transplant, the patient's immune system is temporarily depleted, and so supportive care is vital when the immune system is needing to rebuild. The second type of transplant we will discuss is allogeneic transplant. In allogeneic transplant, cells are collected from a donor who is not the patient, and there is vital genetic matching between the donor and the recipient that is performed prior to selection for the most suitable donor. For allogeneic transplant, healthy donor cells are collected from the donor, and the donor's collected sample is processed to remove the stem cells. Meanwhile, the patient receives conditioning treatment to prepare for their transplant. Following conditioning, donor stem cells are infused into the patient. The stem cells will travel to the patient's marrow to produce new, healthy cells. Similar to autologous transplant, the patient's immune system is temporarily depleted, and supportive care is vital while the immune system rebuilds. There are also additional supportive care considerations with this type of transplant due to the source of stem cells being foreign to the patient. Autologous and allogeneic bone marrow transplant have varying intents and indications for which they are used. The intent of autologous transplant is to reset the immune system to allow for engraftment following transplant. Some indications for autologous transplant include neuroblastoma, Wilms tumor, brain tumors, germ cell tumors, retinoblastoma, Hodgkin and non-Hodgkin lymphoma, and autoimmune diseases. The intent of allogeneic transplant is to rescue the marrow after conditioning regimen is administered to provide graft versus tumor effect or to replace abnormal components of disorders and prevent further damage. Some indications for allogeneic transplant include ALL, AML, CML, MDS, JMML, HLH, primary immune deficiencies, sickle cell disease, bone marrow failure syndromes, and inherited metabolic storage disorders. One of the first steps when proceeding to transplant is to identify a suitable donor. HLA, or histocompatibility typing, and other DNA typing is performed to evaluate the degree of recognition between the donor and recipient cells. The higher the differences in HLA typing, the higher the chance of graft failure and rejection. In a majority of cases, a matched related donor may not be found, and other donor types have to be considered that each carry unique considerations. The donor types include matched related, matched unrelated, haploidentical, mismatched unrelated, and syngeneic. We are not going to go into the details of donor types within the scope of this presentation. Stem cells may be collected from different origins, such as the bone marrow, peripheral blood, and cord blood. Stem cells are collected from the bone marrow by aspiration from the posterior iliac crest until enough cells are removed. It has the advantage of decreased rates of chronic graft versus host disease, or GVHD, but the collection is painful for the donor and also requires anesthesia. With the peripheral blood as a stem cell source, stem cells are collected by apheresis after attempting mobilization. This method allows for ease of collection, has shown faster neutrophil engraftment, and decreased relapse with improved survival. However, in allogeneic transplant, increased frequency and severity of chronic GVHD has been seen because it contains more T cells than the marrow. Cord blood, which is collected from umbilical cord and placenta, serves as another source for stem cells. It is beneficial because it's readily available, and it's a challenge to achieve adequate cells in adults, but this is advantageous in the pediatric population given that only one cord might be enough for their transplant. However, there is a slower neutrophil engraftment and B and T cell immune reconstitution that has been seen. So bone marrow transplant starts with patients receiving a conditioning regimen followed by infusion of stem cells. The day that stem cells are infused is referred to as day 0. Following infusion of stem cells, the process for engraftment begins, and there is a period of pre-engraftment, and then engraftment, and finally post-engraftment. Each of these stages requires different considerations, monitoring, and supportive care to be able to ensure the success of the transplant, which we will begin to discuss in the coming slides. So the first thing we'll be discussing is conditioning therapy and common medications that are used during this phase of transplant. So conditioning regimens are administered prior to the infusion of stem cells to prepare the marrow. It's important to keep in mind that there are circumstances where transplant may be performed without conditioning, such as in children who are being treated for severe combined immunodeficiency. But the goal of conditioning therapy are to, one, eradicate disease, and this means something different for oncology and non-oncology indications. For oncology indications, conditioning therapy allows for high doses of chemotherapy to eradicate disease, and that's followed by infusion of cells to restore bone marrow function. For non-oncology indications, the purpose of conditioning is to use it for immunoablation and to reset the immune system. Other goals include ablation of the marrow and to create space for engraftment, immunosuppression to ensure engraftment and prevent graft versus host disease, and also to avoid overlapping toxicities. Conditioning therapy involves administering high dose and, in some cases, otherwise lethal chemotherapy and total body irradiation. Chemotherapy agents selected have these non-overlapping toxicities, and common agents that are used in pediatric bone marrow transplant regimens are going to be discussed in the following slides. The dose intensity of conditioning regimens can vary, and they are influenced by the indication, patient-related factors such as age, and comorbid conditions. So there's myeloablative conditioning, abbreviated as MAC, and this ablates marrow hematopoiesis and doesn't allow autologous hematologic recovery. There's reduced intensity conditioning, or RIC regimens, and they don't meet the definition for MAC or non-myeloablative conditioning regimens, and these regimens can really vary, and they represent a continuum of intensity. Generally, it's defined as the dose of alkylating agent decreased by greater than or equal to 30%. And patients who receive RIC regimens have prolonged cytopenias, and they may require stem cell support. Lastly, we have non-myeloablative regimens, or NMA regimens, and these cause minimal cytopenias and don't require stem cell support. So total body irradiation, abbreviated as TBI, is administered as conditioning therapy before transplant, and it eradicates malignant cells and also has immunosuppressive properties. So high dose total body irradiation, or TBI, is effective against leukemias and lymphomas and also has that benefit of penetrating sanctuary sites. Though increased doses of TBI reduce the risk of relapse, there is this significant risk for toxicity, such as impaired growth and development, secondary toxicities, and organ dysfunction, which are all concerning, especially within this pediatric population. There are also long-term infectious and non-infectious complications that are seen. Many regimens fractionate the dose of TBI to be able to decrease the risk of those organ toxicities. But TBI has been found to result in endocrine, metabolic, renal, eye, and neurocognitive deficits in greater than 50% of patients. So it's considered to avoid TBI in patients that are less than 3 years of age. Another way to mitigate toxicity of TBI is to use it with chemotherapy agents. And chemotherapy agents can be used without TBI or alone for conditioning. Alkylating agents are going to be the mainstay of chemotherapy-based regimens, as we will see in the next few slides. So the first agent we're going to talk about within our conditioning regimen medications is busulfan. So busulfan was one of the first chemotherapy agents that was used as a replacement for TBI, and it showed less mortality and similar outcomes in myeloid and lymphoid cancers. Busulfan is used for both autologous and allogeneic transplant. It is an alkylating agent that targets non-dividing marrow cells and myeloid precursor cells. Dose-limiting toxicities include veno-occlusive disease, or VOD, also referred to as sinusoidal obstruction syndrome, or SOS, and also pulmonary fibrosis. Busulfan has a narrow therapeutic index and it's subject to interpatient variability. It was previously only available as an oral tablet, and this oral tablet displayed large pharmacokinetic variability and also underwent significant hepatic metabolism. Since, an IV formulation has been developed and it has less erratic pharmacokinetic variability. Busulfan is used in both MAC and RIC regimens, and of note, the doses do vary. Busulfan can be administered every 6, 12, or 24 hours, but for ease of administration, the economic impact, and potentially reducing or minimizing toxicity, many institutions try to utilize every 24-hour dosing for busulfan. Very unique to busulfan is multi-sample pharmacokinetic monitoring, and it's used to calculate the area under the curve, or AUC, and is oftentimes used to monitor the exposure of busulfan and to minimize inferior treatment outcomes. These samples for pharmacokinetic monitoring are collected at different time points after administration of busulfan. And based on the goal cumulative AUC, which varies by center and also the intensity of the regimen, the dose may be adjusted across the days of busulfan administration within the conditioning regimen. So just wanted to reinforce that because of this, doses may change during the days a patient is receiving busulfan. Another thing to remember with busulfan is that it lowers the seizure threshold and contributes to the risk of patients experiencing busulfan-induced seizures. Therefore, seizure prophylaxis is necessary. Anti-epileptic agents such as levetiracetam can be used for prophylaxis, but that medication choice may vary by site. Drug interactions are also prevalent with busulfan. And one drug that raises theoretical concern based on our knowledge of metabolism of this agent is acetaminophen. Acetaminophen reduces glutathione levels in the blood and tissues, so it may inhibit busulfan metabolism and increase busulfan serum levels. The manufacturer recommends to avoid administration of busulfan within 72 hours of starting or finishing busulfan therapy. However, practices do differ among institutions, and oftentimes acetaminophen is held 24 hours before and after administration of busulfan. Additionally, busulfan is metabolized by the cytochrome P450 3A4 system, and there are interactions with agents like phenytoin, metronidazole, and azole antifungals. Melphalan is another agent that is used in autologous and allogeneic transplant. It is an alkylating agent and it targets non-dividing marrow cells and myeloid precursor cells. It has a dose-limiting toxicity of mucositis, and that toxicity can be reduced by utilizing cryotherapy for patients. Other toxicities of melphalan include pulmonary toxicity at doses of greater than 450 milligrams per meter squared, hemorrhagic cystitis, nephrotoxicity, and it has high emetogenicity at doses of greater than or equal to 140 milligrams per meter squared. Melphalan has two products that are available that are given different brand names, and the difference between these two products is their stability. So one of the products is Alcurin, which is stable for 30 minutes, and the second product is Evomela, which is stable for 24 hours. Cyclophosphamide is a chemotherapeutic agent that's used in autologous and allogeneic transplant. It is a prodrug and undergoes metabolism to metabolites that function as alkylating agents. It prevents cell division by cross-linking DNA strands and decreasing DNA synthesis, and it has potent immunosuppressive activity. Dose-limiting toxicities include cardiotoxicity and pulmonary toxicity. A notable toxicity with important supportive care and treatment information pertinent to pharmacists is hemorrhagic cystitis, which occurs because of the acrolein metabolite formation. Mesna is administered as supportive care for doses of cyclophosphamide that are greater than or equal to 1,000 milligrams per meter squared per day. Mesna works by providing a free thiol group that is able to bind and inactivate acrolein. In addition, pre and post hydration are vital to prevent hemorrhagic cystitis, and many centers utilize monitoring for hemorrhagic cystitis on urinalysis. If hemorrhagic cystitis occurs, bladder irrigation, symptom control, selective embolization, urinary diversion, or cystectomy may be used for treatment. Thiotepa is another agent used for conditioning in allogeneic and autologous transplant. It is an alkylating agent that produces cross-linking of DNA strands to induce cell death. Thiotepa has excellent CNS penetration. However, a dose-limiting toxicity that manifests is neurotoxicity, and that must be monitored. Thiotepa is highly toxic to the skin, and measures must be implemented to be able to decrease discomfort and also to reduce cutaneous manifestations. You must remove all occlusive dressings and fitting clothing, and that includes diaper checks, if applicable, from the patient's skin. Also, bathing 3 or 4 times a day is often standard in a lot of hospitals, and so caution must be used in the hospital using bath wipes, chlorhexidine, or adhesives to hold the NG tubes. Thiotepa also carries a high emetogenic potential. Carmustine is used in autologous transplant conditioning regimens. It's a nitrosourea that works through non-enzymatic degradation to products that have alkylating activity and that cause interstrand crosslinks. A dose-limiting toxicity is pulmonary toxicity, and the probability of developing lung toxicity has been found to be exposure-related. Other toxicities include hypotension due to its alcohol-based diluent, and patients should be monitored for woozy feeling and also have increased blood pressure monitoring. Headaches, perioral paresthesia, and flushing can also occur. The next agent that we will discuss is fludarabine, and fludarabine is used in allogeneic transplant. It is a purine analog that has immunosuppressive properties, and its synergistic effect with alkylating agents through DNA repair also make it a great agent that is utilized. Dose-limiting toxicities include neurotoxicity, and the onset of neurotoxicity is usually seen about 2 months after administration. Of note, fludarabine has a risk of prolonged immunosuppression, which is particularly important with these patients, and also making sure that they have important monitoring and supportive care. It's also an important agent historically in RIC regimens, and it's shown to promote engraftment and graft versus leukemia effect and high tolerability. Etoposide is used in autologous and allogeneic transplant. It's a topoisomerase 2 inhibitor, and it has synergistic effect with alkylating agents through DNA repair. Its dose-limiting toxicity is mucositis. There is also a risk of hypotension with etoposide due to the ethanol excipient, and we can mitigate this by utilizing fluids and a slower infusion rate. Myelosuppression is also prevalent with etoposide, as well as the risk of secondary malignancies. The last agent we will be discussing is cytarabine and is seen to be used in autologous transplant. This is a pyrimidine antimetabolite agent. Its dose-limiting toxicity is acute cerebellar toxicity, and it generally occurs 3 to 8 days after treatment. This is why in the hospital, neurochecks are required by nursing prior to each dose that's administered to the patient. Patients also may experience flu-like symptoms that may be referred to as Ara-C syndrome. High-dose regimens are also associated with increased risk of CNS, pulmonary, ocular, and gastrointestinal toxicities. There is that risk of ocular toxicity, and so it's recommended to use prophylaxis with ophthalmic corticosteroids and synthetic eye drops and lubrication. Bone marrow transplant does provide an option for potential cure for patients, but there are certain complications that have been observed with the procedure. As our understanding of transplant has furthered, we are able to better recognize, prevent, and treat complications to promote successful transplant. Some acute complications after transplant include sinusoidal obstructive syndrome, or SOS, also referred to as veno-occlusive disease, VOD, transplant-associated thrombotic microangiopathy, or TA-TMA, idiopathic pneumonia syndrome, or IPS, autoimmune cytopenias, abbreviated AIC, Epstein-Barr virus-associated lymphoproliferative disorder, infection, and acute GVHD. A major chronic complication after transplant that we will discuss is chronic GVHD. So the first complication that we'll discuss is sinusoidal obstructive syndrome, or SOS, previously called veno-occlusive disease, or VOD. This is a life-threatening complication that can occur following conditioning and bone marrow transplant. It occurs because sinusoidal endothelial cells and hepatocytes are damaged by immune-mediated injury and toxic metabolites from chemotherapy. There is deposition of fibrinogen, factor VIII, and erythrocytes, and the components are sloughed off and cause embolization downstream, which leads to venous occlusion. Patients are also in a procoagulant state. The incidence of VOD is greater in pediatric patients, but there is variable reported prevalence due to the different diagnostic criteria that are applied. Factors that put pediatric patients at risk for SOS are young recipient age less than 1 year old, exposure to agents like gemtuzumab and inotuzumab, busulfan or TBI drug exposure, GVHD, liver disease or dysfunction, donor HLA mismatch, and matched unrelated donors and non-T-cell depleted transplant. So symptoms of SOS include fluid retention and ascites, jaundice, weight gain, painful hepatomegaly, and increased abdominal girth. And if severe, it can lead to multi-organ dysfunction, encephalopathy, and death. Of note, children are more prone to drastic changes in weight, so weight gain may be a less objective symptom that's utilized in evaluation. Non-invasive testing can display that ascites, hepatomegaly, and gallbladder wall thickening, and attenuated or reversed hepatic venous flow. Labs may reflect elevated liver function tests as well. So there are three criteria that are used to diagnose SOS. The Baltimore and Seattle criteria were not designed specific to the pediatric population, but the EBMT criteria is specific to this pediatric population. Within the modified Seattle criteria, it lists the criteria to be the presence before day 21 after transplant having greater than or equal to 2 of the following: a bilirubin of greater than or equal to 2 milligrams per deciliter, a weight gain of greater than 5% from baseline, and hepatomegaly or right upper quadrant pain. Within the Baltimore criteria, it lists the presence within 20 days of transplant having a bilirubin of greater than or equal to 2 milligrams per deciliter plus 2 or more of the following, which is weight gain greater than 5% from baseline, hepatomegaly or ascites. And then finally, the EBMT pediatric criteria lists at any time point of onset having greater than or equal to 2 of the following: a bilirubin of greater than or equal to 2 milligrams per deciliter within 72 hours of a rising bilirubin on 3 consecutive days, or weight gain greater than 5% from baseline, or hepatomegaly, ascites, or transfusion refractory thrombocytopenia. Notably, the EBMT pediatric criteria varies from the modified Seattle and Baltimore criteria since it does not require the presence of hyperbilirubinemia for diagnosis of SOS. And this is important because hyperbilirubinemia and jaundice is seen in about only 30% of cases. Also, there is no specific time point of onset within that EBMT pediatric criteria, and about 20% of pediatric patients develop VOD after 30 days of transplant. So SOS generally occurs within 30 days post-transplant, but can occur sooner or later. Ursidile is administered as prophylaxis for VOD, and it works to decrease hepatic damage by replacing hepatotoxic bile acids. Ursidile prophylaxis can be demonstrated to reduce the incidence of SOS in allogeneic transplant. However, the studies have been small and they have some notable weaknesses. Though data on prevention is not strong, prevention does remain key as treatment options once SOS occur are limited. Some patients may require treatment while others can resolve with only observation, but defibrotide is utilized, which works to restore endothelial thrombotic fibrinolytic balance, and it is one agent that has shown efficacy in treatment of SOS in pediatric patients. It's dosed as 6.25 milligrams per kilo per dose, IV every 6 hours. It has been studied as a duration of 21 days. However, it may be utilized for a shorter duration if there are resolution of symptoms. Supportive care is important to use in conjunction with other treatment options as needed, and supportive care techniques include adequate diuresis and fluid restriction. The next complication we will discuss is transplant-associated thrombotic microangiopathy, or TATMA. TATMA generally occurs earlier on following transplant, usually at a median of 35 to 47 days, but it can occur earlier or later depending on the type of transplant. TATMA has a complicated pathophysiology, but essentially it involves activated endothelial cells that create a procoagulant state and activate the complement cascade, leading to TATMA. Signs include the triad, which consists of hypertension, thrombocytopenia, and increased lactate dehydrogenase. This triad is not diagnostic, but patients should receive further evaluation if that triad is present. Also of note, hypertension is often the first sign that may prompt this. Other signs include decreased haptoglobin, schistocytes on the peripheral smear, and acute renal dysfunction or neurologic symptoms. Risk factors include unrelated donor transplant, acute GVHD, and SOS. Management of hypertension is an important step in the treatment of TA-TMA. ACE inhibitors and ARBs may be preferred because of the involvement of the renin-angiotensin system, but patients should be evaluated for kidney dysfunction, and if present, other agents like calcium channel blockers may be preferred instead. Coexisting conditions like infection and GVHD should be treated because they can contribute to endothelial injury caused by TA-TMA. Reducing or stopping calcineurin inhibitors should be considered, as well as adding on an alternative if needed. Of note, sirolimus may not be a good option as an alternative given that it is associated with TA-TMA in combination with tacrolimus. Elevated membrane attack complex levels have been identified in pediatric patients with TA-TMA. And so eculizumab is a monoclonal antibody that is used. It is a monoclonal antibody complement C5 inhibitor, and it prevents membrane attack complex formation. There is a risk with eculizumab for meningococcal disease, and vaccination is recommended at least 2 weeks before treatment start, or if urgent therapy is needed, initiating antimicrobial prophylaxis for 2 weeks. Antimicrobial prophylaxis with penicillins is recommended for the duration of eculizumab therapy. Many other modalities for treatment of TA-TMA have been studied and, as can be seen on this slide, target various targets in the process of TA-TMA development and also endothelial damage. Following transplant, patients are at high risk for infection, and the risk of infection and the type of infection that pose the greatest risk vary from time of transplant. The probability of infection is related to duration and severity of neutropenia, and also important to remember that chemotherapy disrupts that gut mucosal barrier. Before we talk any further, it's important to note that the medication recommendations are not standardized or hard set rules at this time, and they may vary based on institutional guidelines and other resources. The choice of agents may also be influenced by patient-specific factors, drug interactions, and also in patients who are receiving GVHD treatment. The Children's Oncology Group guidance in cancer and transplant recommendations for antimicrobial and antifungal prophylaxis are presented here on this slide. So for antibacterial prophylaxis, their recommendations are no systemic prophylaxis for autologous or allogeneic transplant. However, in allogeneic transplant, considering prophylaxis if there are instances of prolonged neutropenia greater than 7 days during transplant. It is recommended to use fluoroquinolones such as levofloxacin or ciprofloxacin, and noting with ciprofloxacin there is that decreased efficacy against gram-positive bacteria that has been seen. For antifungal prophylaxis, it's recommended for no systemic prophylaxis for autologous transplant, and there is recommended antifungal prophylaxis for allogeneic transplant pre-engraftment or if the patient is receiving systemic immunosuppression for GVHD. It is recommended in this guidance to use echinocandins or mold-active azole antifungals. For ages less than 13 years old, patients have the option of receiving echinocandins, voriconazole, or itraconazole, and for patients greater than 13 years of age, there is a possibility of using posaconazole, echinocandins, voriconazole, and itraconazole. There is also new data surrounding isavuconazole and its utility for antifungal prophylaxis in pediatric patients. This slide displays additional infection prevention that should be considered in patients after transplant. The guidance on this slide is from the Centers for Disease Control in preventing opportunistic infections in stem cell transplant recipients. As on the previous slide, recommendations can vary based on patient characteristics and also institutional practice. So prophylaxis against pneumocystis is recommended while patient is receiving immunosuppression. The medication that's recommended is Bactrim, however, remembering that there is a risk of neutropenia and therefore the use is dependent on institutional preference. Alternatives include pentamidine, which comes as an IV and inhalation, dapsone, and atovaquone. For HSV, VZV prophylaxis, it's recommended that the risk is highest during the pre-engraftment period for HSV and until about day 100 after transplant for VZV. And prophylactic agents recommended during these times are acyclovir or valacyclovir. For CMV, it's recommended to utilize prophylaxis from time of engraftment until 100 days post-transplant. The highest risk for CMV is in patients who have donor-negative, recipient-positive phenotype for CMV, and there might be circumstances or institutional preference for performing preemptive monitoring. Letermovir is an agent that is utilized in adults, has been shown to significantly decrease the risk of CMV after transplant. And there are ongoing studies within the pediatric population for this agent. Other alternative agents include valganciclovir and ganciclovir. The next complication that we will discuss is graft versus host disease, or GVHD, and this is important to discuss because it does contribute to transplant complications, morbidity, and mortality. GVHD occurs when the donor T cells view the host cells as foreign. In the acute setting, antigen-specific effector T cells are induced, which express tissue-specific adhesion receptors and chemoattractant that promote the migration of effector cells and pro-inflammatory cytokines into the organs, which leads to organ damage. Cytokines are also released from damaged tissues. The chronic phase pathophysiology will be further discussed on subsequent slides. GVHD is classified as acute or chronic, and features may overlap, which we will also discuss further in the upcoming slides. Pediatric patients have a lower risk of GVHD in adults, but it is still a phenomenon that requires adequate prophylaxis, monitoring, and treatment. Due to the pathophysiology of GVHD, the risk of GVHD is in allogeneic transplant recipients. Acute GVHD has been historically defined as developing before the 100th day. As explained on the first slide, the pathophysiology involves recognition of recipient antigens by T cells as foreign antigens, and that leads to organ damage. Risk factors for acute GVHD include mismatch in compatibility between the recipient and donor, referred to as HLA disparity, peripheral blood source, older age, sex mismatch, and diarrhea during conditioning. Most commonly, acute GVHD involves the gastrointestinal tract, the skin, and the liver. GVHD prophylaxis is vital to prevent acute and chronic GVHD and the adverse complications that are associated. So on this slide are various drug classes that are used and associated medications and important pearls. Of note, this slide is an overview and the practices of different institutions may vary. Drugs are used in combination regimens or they may be used alone, and that can vary per regimen that's utilized. There is literature available to direct prophylaxis strategies as well, so something that you can look into. The first set of prophylaxis medications rely on immunosuppression. So methotrexate, an antimetabolite, is one of the main agents that's used for GVHD prophylaxis. And though it's effective, it is associated with significant toxicities like mucositis that can lead to early discontinuation of the drug and for dose reductions, which can increase the risk of GVHD and even failure of the graft. Different dosing strategies and dose reductions may be outlined for methotrexate per institution, as well as the antidotes to counter methotrexate toxicity. Liver function abnormalities may occur as a side effect for methotrexate utilization. Calcineurin inhibitors, abbreviated as CNIs, are cyclosporin and tacrolimus, and they are also frequently used for GVHD prophylaxis. It's important to note that these agents require trough monitoring, and the goals that are utilized may vary by institution. CNIs are conveniently available in many formulations as outlined on this slide. Tacrolimus and cyclosporin are major substrates of CYP3A4 and P-glycoprotein, so it's important to note the significant drug interactions that can occur and screen patients' medication lists. So for example, in the package insert for cyclosporin, dose adjustment of lotiramivir is mentioned to 240 milligrams, and that's required with co-administration. Another commonly used medication for GVHD prophylaxis is sirolimus, which is an mTOR inhibitor. This drug also requires trough monitoring with trough goals that may vary based on institutional practice. It's important to note that sirolimus may impair wound healing, so this should be kept in mind if a patient has or is expected to have a procedure or has any wounds that might require healing. Mycophenolate, abbreviated as MMF, is an antimetabolite that can be used for GVHD prophylaxis. And this medication has notable side effects of neutropenia and also gastrointestinal upset. The next category is T-cell targeting agents, and these are a developing prophylaxis strategy. The previous therapies discussed prevent GVHD by immunosuppression, but this can hinder the graft versus leukemia effect that we are desiring. Therefore, new treatment strategies are attempting to maintain that graft versus leukemia effect and target T-cell activities seen in acute and chronic GVHD processes. T-cell targeting drugs include abatacept, ATG, alemtuzumab, and also post-transplant cyclophosphamide. To reduce the risk of GVHD, T cells may be depleted in or ex vivo. Ex vivo depletion techniques involve cellular graft manipulation to be able to decrease the risk of GVHD. One culprit for causing GVHD are alpha-beta T cells, and so alpha-beta depletion may be used which spares NK cells. There are studies that are ongoing in the pediatric population for this strategy. And this approach allows us to eliminate post-transplant immunosuppression and the associated side effects. Also notably, abatacept has a recent FDA approval in patients greater than 2 years old combined with CNI and methotrexate. With this drug, antiviral prophylaxis for EBV before treatment until 6 months post-treatment is necessary to consider. ATG is an option for prophylaxis, but increased risk of relapse has been seen with ATG use. Alemtuzumab is also an option that can be used, but it increases the risk of immunosuppression, and that can increase post-transplant complications. Sometimes our prophylaxis strategies just aren't enough, and patients will develop acute GVHD. For acute GVHD treatment, steroids are considered first-line options. So recommendations are for methylprednisolone dosed at 0.5 to 2 milligrams per kilo per day. And the NCCN also provides guidance for assessing if patients are refractory to steroid therapy and when subsequent therapy may need to be considered. They outline steroid refractory as progression within 3 to 5 days of treatment start with greater than or equal to 2 milligrams per kilogram per day of prednisone equivalent. Also, if they have no improvement within 5 to 7 days of treatment start, or if they have incomplete response after greater than 20 days of treatment, including steroids and immunosuppression. If patients are refractory to therapy, there are second-line options, and ruxolitinib is an important agent that's approved for treatment of acute GVHD in adults and children 12 years of age and older who have failed corticosteroid therapy. Ruxolitinib is a JAK1 and 2 protein kinase competitive inhibitor, and JAK1 and 2 mediate cytokine and growth factor signaling and play a role in the development, proliferation, and activation of the immune cells that contribute to pathogenesis of acute GVHD. Other agents that may be utilized in the second-line setting are also listed at the bottom of this slide. Over time, as alluded to previously, the definition of chronic GVHD has changed due to our improved understanding of the pathophysiology and clinical and histologic changes seen. So historically, chronic GVHD has been defined as developing after the 100th day. However, there is possible overlap with acute GVHD since the histological and clinical changes can happen earlier post-transplant and overlap with acute GVHD. The pathophysiology of chronic GVHD is complex, but there are many hypothesized mechanisms. In general, it involves alloreactive T cells and a possible role of B lymphocytes in production of antibodies and presentation of antigens. Risk factors include age greater than 10 years old, myeloablative and total body irradiation, including regimens, HLA disparity, peripheral blood transplant, or history of acute GVHD. The immune mechanisms differ between acute and chronic GVHD, and there is further research and development being conducted for treatment for chronic GVHD. However, in the first line, steroid therapy is recommended with methylprednisolone 0.5 to 1 milligrams per kilogram per day or prednisone equivalents. Per the NCCN guidelines, patients are classified as refractory to steroids if they have progression on greater than or equal to 1 milligram per kilogram per day prednisone for 1 to 2 weeks, or have stable GVHD on greater than or equal to 0.5 milligrams per kilogram per day prednisone for 1 to 2 months. Second line options can then be considered. Ruxolitinib is FDA approved in adults and children 12 years of age and older with chronic GVHD following the failure of 1 or 2 lines of treatment. And another agent is belumosudil, and that can be used for the treatment of chronic GVHD. The mechanism differs from ruxolitinib. Belumosudil is an inhibitor of Rho-associated coil kinase 2 or ROCK2. The inhibition works to dampen the inflammatory cascade and also targets fibrosis. It is currently approved for adult and pediatric patients 12 years of age and older with chronic GVHD after failure of at least 2 prior lines of therapy. There are other treatment options with varying levels of data and efficacy, and they're listed on this slide for your reference. And finally, on this slide are some wonderful resources that you can use and access to learn more about the concepts that I discussed in this presentation, and also beyond that about bone marrow transplant. So to wrap up this presentation, I have a few review questions that we will go over together. So the first question is, which of the following statements is false? Is it A, an autologous transplant, cells are collected from a healthy donor? B, acute myeloid leukemia can be treated by an allogeneic transplant? C, autoimmune disease can be treated with an autologous transplant? Or D, stem cell sources include cord blood, peripheral blood, and bone marrow? So the correct answer is A. So if you recall, in autologous transplant, the patient serves as the donor. So that's why that first statement is false. Okay, so question number 2 is a patient case. SP receives a transplant with busulfan, cyclophosphamide, and etoposide. On day 18 following transplant, the patient's labs are notable for hyperbilirubinemia and fluid retention is noted in her legs. The team is concerned for SOS. What agent is appropriate to use? Is it A, mycophenolate, B, cyclosporin, C, defibrotide, or D, no treatment is needed since this is a transient and non-serious complication? So the correct answer is C, defibrotide. Although we mentioned and discussed that there is some strong data that's lacking for defibrotide, it has shown efficacy in treatment of SOS. Treatment here is likely necessary because SOS can be fatal, especially when it is developing quickly. Okay, so our next question is, which of the following is not the correct match for infection and prophylaxis method? Is it A, PJP prophylaxis and pentamidine, B, fungal prophylaxis and fluconazole, C, viral prophylaxis and sulfamethoxazole trimethoprim, or D, bacterial prophylaxis and levofloxacin? The correct answer is C. So viral and sulfamethoxazole trimethoprim do not go together. Sulfamethoxazole trimethoprim is used for PJP prophylaxis, not viral prophylaxis. Our options for viral prophylaxis agents include things like acyclovir and valacyclovir. Question number 4 is another patient case. So JT is a 13-year-old female with a history of acute myeloid leukemia who will receive a peripheral blood transplant. Her conditioning regimen will contain busulfan and cyclophosphamide. Which of the following side effects are most important to monitor for with her regimen? Is it A, pulmonary toxicity, B, ocular toxicity, C, hypotension, and D, hyperpigmentation? So the correct answer here is A, pulmonary toxicity. As you may recall, we discussed pulmonary fibrosis being a dose-limiting toxicity of busulfan and definitely something that we should monitor with this regimen. If you would like a refresher on the other toxicities and medications that they might be associated with, you can go back to those conditioning regimen slides and review the medications. And our last question is an extension of the previous case. So in that case, which of the following is a risk factor for GVHD for JT? Is it A, peripheral blood stem cell source, B, mismatched donor, C, conditioning regimen, or D, A and B? The correct answer is D, both A, peripheral blood stem cell source, and B, mismatched donor or HLA disparity are risk factors for GVHD. Other risk factors we discussed include older age, sex mismatch, and also diarrhea during conditioning. So we have covered quite a lot of information through this presentation. We have discussed definitions of autologous and allogeneic bone marrow transplant in pediatric patients and that they vary based on indication. Conditioning regimens prior to transplant vary in intensity, and the agents used for conditioning have unique side effects that require monitoring and intervention should they occur. It's also important to take away that following transplant, patients are at increased risk of complications and they must receive monitoring, supportive care, and treatment accordingly. And lastly, we covered that graft versus host disease can be either acute or chronic, and prevention is really key to minimize mortality. And we have a variety of different treatment options for both acute and chronic GVHD. And here are some additional references I used to create this slide set. Thank you so much for your time, and I hope you were able to learn more about bone marrow transplant in pediatric patients.